Hi everybody, welcome to Dr. Manny's YouTube Learn Shops. This Learn Shop is in 5 parts and we'll start with part 1 to do with temporary cardiac pacing. These temporary pacing workshops are for nurses who care for patients who require temporary pacing and which are often associated with problems related to acquired heart disease. And they will provide you with an insight after reviewing fundamentals about various types of systems and selected pacing modes. And we'll look at certain ECG pacing rhythms as we go through as well. So the learning objectives for this Learn Shop, part 1 are: review pre-workshop knowledge, cardiac conduction again, pacing requirements, electrodes, the cable, pulse generators and safety, but as an overview essentially. So let's look at the knowledge review. What do you know? The intrinsic cardiac rhythm refers to which of the following statements? A, B, C, or D? The correct answer is A, the patient's own heart rhythm. Which of the following statements explains the relative refractory period? Is it A, B, C, or D? Well, all of them pertain to the relative refractory period. Which of the following relate to the R on T phenomenon? A, B, C, or D? The correct answer in relation to the R on T phenomenon is all of the above. Which of the following best describes the millivolt? A, B, C, or D? The correct answer is A, the unit which measures the amplitude or size on the ECG. Which of the following connects to asynchronous atrial pacing? A, B, C, or D? The correct answer is D, all of the above. Which of the following best explains the demand mode pacing? A, B, C, or none of the above, D? The correct answer is A. Question 7. AV sequential pacing is best explained by which of the following? A, B, C, or D? The correct answer is D. Question 8. Which of the following statements is true? A, B, C, or is it D? The correct answer is all the above are true. Which of the following is the intrinsic cardiac pacemaker? SA node, AV node, bundle of His or Purkinje fibres? The correct answer is A, the sinoatrial node. Which of the following does the P wave represent? Atrial depolarization, nodal depolarization, ventricular depolarization, or all of the above? The correct answer is atrial depolarization. What about the following? Can you name this pacemaker mode on the ECG rhythm? The correct answer is AOO or AAI. This is atrial pacing. What about this pacemaker mode? This could be VOO or VVI, ventricular pacing. What about this pacemaker mode? This is AV sequential pacing. Alright, let's review cardiac pacing then. Cardiac pacing is essentially a medical intervention to stimulate the heart with an electrical current when the inherent cardiac conduction system fails. The cardiac conduction system we reviewed previously consists of the SA node, the atrial pathways, the AV node, the His node, the bundle branches, and the Purkinje fibers. The SA node is essentially the intrinsic inherent pacemaker, which is sited in the subepicardium at the junction of the superior vena cava and the right atrium, and it depolarizes at rest at approximately 60 to 100 times per minute in an adult. The intraatrial pathways consist of Bachmann, Wenke, Bach and Thorell, and they have a depolarization speed through the atria of approximately 1,000 millimeters per second. The AV node then is the secondary or backup pacemaker, and it has a depolarization speed that is markedly reduced from the intraatrial pathways down to 200 millimeters per second in order to give time to the atria to contract and empty their contents, blood, into the ventricles. It's sited the distal AV node, the His bundle, and the atrioventricular junction. It depolarizes at rest between 40 and 60 times per minute. The His-Purkinje system is considered to be the tertiary or backup pacemaker, but it's unreliable. It's not actually pacemaker tissue, only the SA node and AV node are. It's sited at the subepicardium, in the ventricular septum, which become bundle branches, and eventually the myocardium, the Purkinje fibers. And it depolarizes at rest at around about 20 to 40 times per minute. It's got a depolarization speed which is markedly increased from the AV nodes, 200 millimeters per second, to 5,000 millimeters per second in order to depolarize all the ventricular myocardium at the same time, synchrony, to provide effective contraction and therefore cardiac output. When we look at the cardiac pacing requirements, they are essentially electrodes, cables, and a pulse generator. As with all practices, we need competent, safe practitioners first. When it comes to pacing electrodes, generic pacing electrodes consist of unipolar and bipolar. Unipolar from 1 point, bipolar from 2 points. Unipolar depolarize and stimulate the myocardium. Bipolar do both. Depolarize and stimulate the myocardium and sense inherent myopotentials. Cardiac pacing electrodes can be of the following. They can be epicardial, outside the heart, typically after cardiac surgery. They can be transvenous, going into a vein and then into the right ventricle. They can also be transcutaneous, which means pads that are placed outside on the chest, either in an anterior or a lateral position, or an anterior or a posterior position, which we'll review. When it comes to epicardial pacing electrodes, they can be atrial, ventricular, or both atrial and ventricular, depending on the surgery that's been performed and the safety issues that are required. With epicardial pacing electrodes, you can see on this chest x-ray, they're located atrial and identified ventricular. When we look at transvenous pacing electrodes, there are certain variations, but typically you have a lead with electrodes at the end. The proximal electrode is the positive electrode and the distal electrode is the negative electrode. And you have connections which are both positive and negative, which have to be connected into the pulse generator, the pacemaker box, in the correct way. Otherwise, you don't provide the correct stimulation or sensing. Now, the distal electrode, the negative electrode, typically, if connected correctly, delivers the current to the myocardium, has best contact with the myocardium, and causes the myocardium to contract. The proximal or positive electrode, which is located beneath the distal electrode, is primarily responsible for sensing and returning the current back to the pulse generator. Distal, current out; proximal, current back in. It completes a circuit. There are other variations that can be related to catheters such as the Swan-Ganz catheter. And look, I mean, they can be really quite involved. These are just some of the variations. What I just previously described is typically the simplest pacing temporary transvenous pulse generator. If we look at the transvenous pacing electrodes, you can see on this chest x-ray, this one is going into the jugular, which the catheter goes into the superior vena cava, then into the right atrium and into the right ventricle, identified by the square. Here's another example. These are now atrial and ventricular pacing electrodes. And this one is going, or has been attached to, a permanent pacemaker. But they can be temporary. Unlikely. Normally, atrial and ventricular pacing wires are permanent. Then you've got transcutaneous pacing electrodes, and these are just pads that are attached to the chest. And they can be attached in a variety of different placement options, such as anterior lateral, seen in the picture, or anterior posterior. When we look at the pacing cables, these are just some examples. So these are extension cables, which again have a distal and a proximal connection. The distal is typically coloured black and the proximal is typically coloured white. Distal is negative, proximal is positive. However, there can be variations in colour. The proximal can sometimes be red, but typically the distal is always black. When handling the pacing wire or electrode and the pacing cable, there are certain cautions that we should be aware of. And we should always wear rubber gloves to prevent static electricity, which can be transferred from your hands to the cable, which is connected to the inside or located to the inside of the heart. And this can cause static electricity to be transferred and initiate a life-threatening rhythm. So when handling pacing electrodes that are exposed as these are, we should always wear rubber gloves as a safety issue. An additional caution should be ensure that the cable is always securely locked into the pulse generator, because if it becomes disconnected, then the battery isn't connected to the cable, and if it's not connected to the cable, current can't be delivered to the heart and the pacemaker will not function. Always remember as well, especially post-cardiac surgery, that some electrodes do not lock into the pulse generator and they can become easily disconnected, and if they do, the pulse generator and the patient are no longer connected and the pacemaker will not do what it's supposed to do. When we look at pulse generators, and I've just used the Medtronic as an example, there are lots of pacemakers, but the pulse generator is essentially what generates the pulse of current, and this is essentially the pacemaker box. The pacemaker can be a dual chamber, which means it can pace the atria and the ventricles, or it can be single chamber and pace either the atria or just the ventricles. Typically, single chamber is used for pacing the ventricle, and the dual chamber can be used for pacing either the atria or the ventricles or both. When we look at the pulse generator dials, we can look now here, and most pacemakers basically have the same dials. You have the pacemaker rate, which is typically between 30 and 180 pulsations per minute. So this establishes the heart rate. Then you've got the output, which is typically from 0.1 to 20 milliamps, and this delivers the electrical current, either low or high. 0.1 being the lowest, 20 milliamps is the highest. Then you've got the sensitivity dial, and the sensitivity dial basically makes the pacemaker, which is the machine, sensitive to the patient's inherent underlying heart rhythm if they have one, because you don't want the pacemaker pacing and competing with the patient's own heart rhythm if it's hemodynamically stable, which it could be as they recover from whatever problem it was that they had the pacemaker inserted for. So the sensitivity can be very, very, very sensitive, which is referred to as most sensitive, at 0.5 millivolts. And take note, the lower the figure with the sensitivity dial, the more sensitive the pacemaker is to the patient's inherent myopotentials or heartbeat. And by being on 0.5 millivolts, it's in the demand mode. It's in the synchronous mode, and it will only typically help if required. When you've got the least sensitivity, 20 millivolts, or as it indicates on your pulse generator there, asynchronous, it's the least sensitive. So look at the figure, 20 millivolts. You would assume that it would be the most sensitive, but it's not. 20 or asynchronous mode means fixed mode pacing, which means the pacemaker will just do what it wants to do according to the settings. This is like a control mode. So you have the heart rate, or the pacemaker rate in pulsations per minute. You have the output, which delivers the electrical current, either at a low strength or a high strength. And you have the sensitivity dial, which makes the pacemaker aware of the patient's inherent heartbeat if required. Other indicators on the pacemaker or the pulse generator are a low battery light. The low battery light will come on when the battery is low, and typically most pulse generators demonstrate this light when you only have 24 hours of battery life left. Active pacing, which means the pulse generator is actually pacing, there's a green light which comes on which says I'm pacing the patient. Then you've got a yellow light which indicates active sensing, which means the pacemaker is sensing that the patient is doing their own thing, own inherent heartbeat, and it will turn the active pacing off and indicate to you that it is actively sensing. most pacemakers have what is called overdrive pacing as well, which means you can go to very, very fast heart rates, 300, 400, 500 pulsations per minute, to overdrive an atrial tachyarrhythmia that maybe doesn't respond to medication, or medication isn't appropriate for that patient. And all pulse generators have an on-off button, which turns the pacemaker on. If you want to turn it off, typically you have to keep your finger on the off button for a prolonged period of time as a safety feature. This is the typical pulse generator dials. Okay, all temporary pacemakers typically have a battery. And as I mentioned previously, the low battery indicator flashes yellow with 24 hours of battery charge remaining. And that seems to be pretty typical with most pulse generators that provide temporary pacing. The battery is typically a 9-volt alkaline battery, and typically you get 2 weeks use for it with continuous use. However, look, the battery should be changed whenever you are commencing temporary use with any new patient. Okay, that's the end of part 1. Thanks. If you found this of any value, please continue to part 2. And look, suggest it to your other colleagues if you found this to be valuable. See you in part 2.